Hello, everybody. It's my pleasure today to participate in the interview of Dr. Thara, who is a speaker in one of the symposia that will take place during the 2021 SIRS Congress in April. And we will have an early career awardee, Rakshati is her first name, who will interview Dr. Thara. I'm Silvana Galderisi, professor of psychiatry at University of Campania, Luigi Vanvitelli. And now the floor is yours. Rakshati, please, you will introduce yourself and then we will have Dr. Thara introducing herself and then taking your questions. Thank you.
Good morning, everyone. I'm Dr. Rakshati Basavaraju. I'm a psychiatrist, currently a postdoc research scientist in Columbia University Medical Center, specializing in neuroimaging in major psychiatric disorders, including schizophrenia. So I consider it my privilege to be a part of the symposium featuring some of the great psychiatrists of this world working in schizophrenia and disability and negative symptoms and cognitive symptoms. That's Dr. Thara Rangaswamy and Dr. Sylvana Galderesi. Over to Dr. Thara Rangaswamy for the talk.
Hi, I'm Thara and I'm a psychiatrist, probably has been working for over 35 years, only in India. I am the co-founder and now the director of research of a not-for-profit organization, a non-governmental organization called SCARF, which is a Schizophrenia Research Foundation, which is a WHO collaborating center for mental health research and training. And my areas of interest are, of course, schizophrenia, psychopathology, especially cause and outcome. I have completed a 35-year follow-up of first episode psychosis in Chennai, in India, and disability, surely, and everything else goes with it, community mental health, outreach, and so on. So that's it in brief.
Rakshati, I think you can start with the questions you would like to ask Dr. Thara concerning her speech during the symposium.
Yeah. So the topic of Dr. Thara's presentation today will be about the outcomes of psychosis in low and middle income countries. And so I would like to ask Dr. Thara on her experience on this topic. I mean, why is this important to be studied, especially the outcomes of psychosis in low and middle income countries separately? How does it stand different from the other countries?
Well, I think it is very important to understand how a disorder progresses and what eventually happens to it, which is what we call outcome. And that is not just for academic interest, but I think it is necessary to tailor your interventions based on the knowledge of outcomes and prognosis. And the reason it is so important in many low and middle income countries is not merely because it is different. I mean, there are many studies, a lot of research which has shown that outcome in developing countries is better than developed countries. And this is still being argued about, and a lot of discussions are still going on. But even if you take, for example, the work that I'm going to be presenting in the symposium, I'm going to be basically looking at 3 different kinds of samples, all from the state of Tamil Nadu. 2 of them are rural and 1 of them is urban. And we have found some fascinating differences in the cause, in the response to treatment, the levels of stigma, and finally the outcome. Just the differences between urban areas and rural areas itself is so fascinating, let alone the differences between developed countries and developing countries.
So, what are the challenges you met while carrying out such a research in a developing world?
See, if research is not challenging, it's not interesting. Okay, so it becomes a mundane activity. So one has to have challenges, one has to have difficulties, and one has to learn how to cope with them and how to deal with them. You know, that is all. That's what gives you the passion and interest in this kind of research. And as far as follow-up studies in India, or for that matter, many of our countries is concerned, uh, it is fraught with a lot of problems because we do not have anything like case registers. We do not know when people move, they could just migrate, they could change their homes, they could change their addresses. They never need to tell you all that. You know? So they could just do it. And therefore, you really don't have a clue of where they have gone 6 months from now or 1 year from now. So that is a huge challenge that we face even in urban areas. You know, urban migration is very, very common in large cities like Chennai. And as you well know, persons with severe mental disorders are more prone to change houses because of problems with their neighborhood and problems with their house owner and so on. So that is one aspect of it. The other aspect of it is the attrition we have. As I said, the dropout rates. People who become well, I have published many papers on this. People who become well do not want to come for follow up because I'm fine. I mean, why should I keep seeing the doctor? It doesn't make any sense to me. And the third very important aspect of our attrition are the deaths. The mortality rates in low middle income countries of people with severe psychosis is very, very high. And in fact, that is one of the things which makes us feel that, after all, if you take into account mortality, outcome is not all that glamorous, you know. So because people are dying due to various causes. And again, the tragedy is we don't quite know why they are dying. You know, very often, I mean, this could happen even with normal people. They will say he went to sleep and he didn't get up in the morning, he had a heart attack, you know, and things like that. And because there is not this mandatory post-mortem that we have to do, we never get to know the real causes of death in many of our patients. Uh, of course, we are addressing the issues of physical comorbidity now more aggressively, also because of the second generation antipsychotics we use. But nevertheless, mortality in schizophrenia or in psychosis is still an enigma as far as we are concerned. And that is true even of urban areas. And just imagine what it will be in a rural, remote village where the person just dies and nobody really even bothers to find out why he or she has died. So this again is a major challenge.
Interesting.
I can go on talking about many challenges, but I think I'll let you ask questions.
Thank you. Thank you for that. That was a very good opening to the talk. My another question would be, uh, why should the outcomes in of psychosis be different in middle and low income countries? So if I ask you, what are the main factors leading to different outcomes? For example, is it economic? Is it cultural? Is it genetic, bar biological? Or what are the main factors that actually differentiate the course of the illness in a developing versus a developed world?
See, the point is there are some studies, especially the WHO coordinated studies, which have said outcome is better in developing countries. But the black box has not been opened yet. You know, we still do not know exactly why this is happening. It is all very, very hypothetical. We are saying it is family support, more social support, more acceptance by society, maybe less stigma, maybe less demands on the person with severe mental disability because the family is taking care of him. But believe me, these are all hypotheses, which are in some studies, we are testing them out. Just now, we are doing what is called an intrepid study, about which I'm going to be talking, which is done in psychosis in India, in Chennai, in Nigeria, and in Trinidad. So we are comparing the three sites where we are looking at some of these aspects. But until now, just like we can't say what causes schizophrenia, you know, can't be categorical about it. we cannot say why outcome is better in one place and not so good in another place. So we can keep on discussing, but we still haven't got that magic solution yet.
Yes. Thank you. Thank you for the response. Maybe we can go ahead with the talk right now, with the presentation by Dr. Rangaswamy.
Oh, you want me to talk about what I'm going to say in the symposium?
Yes.
So as I mentioned earlier, we have these 3 huge samples of first episode psychosis that we have been following up for varying periods of time. 2 of them are rural and 1 of them is urban. And the most fascinating thing about rural patients is you may call it first episode, but if you look at the duration of psychosis, that is DUP, the mean DUP is about 9 years. So the DUP is anything from 1 year to 35 years is what we have seen in rural areas. We won't go into why this is happening, why people are not seeking treatment. I mean, that's a big world by itself. But the fact remains that people are not seeking help, they are not seeking treatment, or there are no facilities available. You know, it's a question of availability or accessibility, whatever it is. Therefore, the DUP is, as I said, mean DUP of 9 years. So by the time we actually reach to them, they are chronic, they are disabled, they are probably never treated. Although we do have about 25% of them who have gone to some mental health service, they've gone there a couple of times, they've taken some medication and then stopped it because the family was not motivated enough to continue treatment. As I said, we will not discuss why now, but it will all be discussed at the symposium. This is 2 of the other intrepid study which we are currently doing now. Again, in a rural place where the DUP is about 9 years. But a very interesting thing that we found was that when you go to measure the level of cognition in these people, I mean, you were asking about challenges, right? Yeah. So this is a huge challenge. Measuring cognition in semi-literate or illiterate persons with psychosis in rural areas is a huge challenge. And this is something that we have seen for like 15, 20 years. However simplistic the instrument you use, you are still not on very firm grounds. You're not sure that if you are really measuring true cognition in these people. And what we have found, apart from other factors, that they're not able to concentrate, they're not able to focus, there's no privacy, there are some 20 people standing around them when they are actually taking these tests, you know. So apart from all these factors, education seems to be a very important factor. And mind you, this education is cutting across all groups. It does not seem to be applicable only to patients. It seems to be equally applicable to control normal population. So this is another challenge that we face. How do we connect neurocognition in these patients with psychopathology, vis-a-vis treatment, vis-a-vis course, outcome, and so on. So that's another interesting facet that I'm going to be talking about in the symposium. Then we have another program which we just wound up because we didn't have the resources, and that was a mobile telepsychiatry program, one of its kind in Asia, probably in the world, where we had a bus fitted with all the mobile equipment, telepsychiatry equipment, and we took the bus to rural areas and connected there with the patients. And there again, this was a catchment area based survey that we did in order to find patients. And there again, we found close to 40% had never been treated. They would have gone to religious sites, they might have gone to the temple or dargah or church or whatever, taken some religious treatment, magical religious treatment, and that's it. They have never really had a proper treatment at all for their psychosis.
Well, thank you very much. I think this is really a fantastic interview. I'm enjoying it quite a lot, but I do think that we should now try to close the interview because it shouldn't be too long in order to let people also find the time to enjoy it. I just would like to pose one last question, very brief. Do you think that the fact that the duration of untreated psychosis is so long has something to do also with the high rate of mortality? Do you think it contributes?
No, I'm not sure it does, because I think DUP is primarily related to the health services that are available, number one, and two, to the explanatory models that people have about mental illness, whether they see it as a disorder or they see it as a magico-religious phenomenon, which makes them seek treatment elsewhere.
Can I ask one last question?
Sure.
Sorry to interrupt you.
Yeah.
I had a question.
Sorry, go ahead.
Sorry, yeah. I had a question. How does the legal system make a difference in the outcome? Like whether the Mental Health Act, which is different between the developing and the developed world, makes any difference in the
outcome? It's too premature. The Mental Health Act has been around just for a couple of years and been implemented in phases. So I think that that's a bit premature to say whether that has really made an impact on the outcomes.
Yeah, thank you. That was my question.
So
thank you very much for this opportunity, and I hope you'll all come and attend our symposium. I'm sure you'll find it very fascinating because we are cutting across many cultures in the world.
Sure.
We thank you very, very much for making yourself available for the interview. And also thanks a lot to Rakshati for conducting the interview. Thank you so much.